Okay, great. The mic works. So thanks, everyone. Really happy to be here and excited. Thanks for the invitation to come and talk about this past year's experience at the VA and maybe some last year topics surrounding quality improvement in general and its place in medicine. So we'll actually start in the beginning, and this is actually a slide from my predecessor's Grand Rounds talk last year, Nick Mayo. So actually, I'll have Nick wave hi real quick. So this is Nick, and this was his slide, and it was titled "The Airplane in Our Living Room: Internal Medicine Training in the Era of Accountable Care." And the talk that I'm giving today is kind of designed as a natural sequel to this, and perhaps also an extension of the conversation that Dr. Hirschman started last week about the profession of medicine. And through this talk, we'll actually, I hope, have an opportunity to discuss exactly how this airplane landed in our living room as well. But also to give a bit of orientation as well as some reorientation to some of the residents in the room. This is a slide that they should be fairly familiar with. In teaching the health system seminar earlier last year, this was one of the first slides that I put up, and it's an image of the two Bills who shaped modern Seattle, so William Boeing on the left and Bill Gates on the right. And the setup was that we talked about how these individuals lived in times of monumental change. And rather than shrink from that change or try to fight a losing battle to hold it at bay, they instead embraced the upheaval, harnessed it, and did incredible things with that, so that these gentlemen and the creations that they left the world with changed the shape of modern human history. And so we left that course on this slide here using to borrow Boeing's current corporate slogan, which is "Build Something Better," and as an entreaty to the residents to go out there and improve the places where they worked. And I'll just point out that it is Boeing's centennial this year, so there's a lot of Boeing stuff in here. But I always felt that this particular slogan was a little bit blunt and lacked a certain je ne sais quoi. And I've always liked the version that they had before, which was "Forever New Frontiers." And this always, to me, has evoked something about what we want to talk about today, which is the future and the path to get there. So we'll start with disclosures. So people ask me, why did I come to residency in Seattle? And it's a great program, but the two answers I do always want to mention is that I like airplanes and I love coffee, and there's a couple of gallons at least of this stuff in this PowerPoint deck, and I'm trying to infuse a little bit in this morning as well. So this is what we'll cover today, just in general outline form. We'll introduce some of the work in terms of teaching quality improvement over the summer, some of the projects that I've been doing at the VA, and then so from that ground level, sort of zoom up towards more philosophical points about the purpose of quality improvement, the complexity of medicine today, and then sort of where do we go next. So this is where we started in the summer of 2015, and these are sort of the first activities as part of this chief resident role, is to teach the internal medicine health system summer seminar series, do this QI boot camp thing that we've deployed at various places, and then to be the co-lead of the UW House Staff Quality and Safety Committee. And so we'll start with the Health System Summer Seminar Series, which has been abbreviated into HSSSSSSS. And so this was a great thing, and through the extraordinary work of help from Nick Mayo, Kelly Corning, and Anders Chen, we were able to bring more or less almost all of the R2s and R3s in the program together for a 4-week course on the principles of quality improvement. So they did things like a root cause analysis, process maps, did some prospective risk assessments, and then sort of learned how to build a successful QI project. And to start with, we actually pulled their own readmissions data from the UW Medical Center database and had them sort of critically examine what happened in these readmissions cases and identify sort of systems flaws that contributed to the patients returning to the hospital. And from that identification of a process that didn't work quite as expected, they studied that process in greater depth and did this thing here to sort of calculate what may be the most likely or the most catastrophic scenarios for that process to go wrong. And from this, they subsequently developed an improvement project, basically as a simulation. And so this course was delivered over the span of about a month in 2-hour chunks. And most of them liked it. They thought it was valuable to training, that it was novel, although about 22% were confused, as if wondering if they'd seen it before, but certainly if they had seen it before, it wasn't memorable enough to recall that they had seen it before. And then the majority thought that it should be continued being taught to residents, and that's great because we are going to do that. It's going to be taught again. So, and these are the folks behind it, and some really wonderful Department of Medicine and General and Internal Medicine staff here who participated, without whose assistance this could not have gone off with that number of residents, especially. From that, we always want to improve on the things that we do. So we took that basic concept and we optimized that design, made it a little bit shorter, more compact, more streamlined. And this was built into a boot camp, a 90-minute boot camp session that we've had the opportunity to deliver at various venues, most notably recently Northwest Regional at SGEM. And I think Nick is going to take it into some other venues this year for faculty development. And that too had some pretty good reviews, and folks thought that it would change at least the way they would teach at their home institutions. And one of my other activities then is to be the co-chair of the UW House Staff and Quality and Safety Committee. And for those folks who haven't seen, who aren't aware of this committee yet, it's basically a group of, it's a House staff-led group that's dedicated to promoting and advancing quality improvement throughout UW Medicine. There's about 40 residents and fellows currently, and representing something like 20 different specialties. So this has been a really wonderful experience, and it's about the best sort of on-the-job management training that we can get, because part of the process is to sort of manage and put forward very large projects. And this is one of those that was started by Nick and Irving Yee in anesthesia a year ago. This is QI Max, and some of you may be familiar with it, but it's essentially an online matchmaking service where faculty with projects in QI can post, and then house staff who are interested in joining in quality improvement work can go on, kind of look at what they like in a project and sign on. So these are screenshots from version 1, and version 2 is now currently in development with the help of orthopedic surgery. And has anyone worked with these medical students? You shouldn't have, because they're from Tulane. And so, so we had the opportunity to present QI Match at the IHI National Forum last year, and this fella over on the right here, he came up while I was talking to someone else and just started snapping photos and texting his friends, and they all came over, and basically their question was, dude, can we get the code for that? And so QI Match, especially in this sort of, in the newest generation that are really tech savvy, this is something that they like, and we'll have the opportunity to showcase this again at the AAMC conference in June, and already there's interest from Arizona, University of Arizona College of Medicine, and just recently got an email from Albert Einstein talking about, hey, this is something we're interested in developing ourselves, can we talk a bit more? So there's interest potentially nationwide in this as well. So within UW Medicine, we also have made an effort to sort of just spread the news about all the great quality improvement work that's been going on, faculty-led and resident participated or resident-led de novo. And so this is, we've been trying to do that through publication. This is our annual news magazine, House. The first issue came out in the winter of 2015. The next volume is taking submissions, so if you have work, talk to me that you want to put in this, talk to me afterwards. And then more recently, we started a quarterly newsletter called Brick, a building block of House. So, and basically, this is sort of what I feel is the evolution of medical education over the past half-century plus. And I really do firmly believe that QI is the next frontier in medical education. And through this year, through the work in the HQSC and this role as the Chief Resident of Quality of Safety, which is a national VA program, I've been really fortunate to be able to not only sort of teach the fundamentals of quality improvement, but also lay some of the infrastructure and sow some of the cultural seeds that will be necessary for the skills that we teach to really flourish. And it's harnessing things like the ACGME clinical learning environment review and leveraging that to advance this. So I really do believe that QI is the next step. And it's very exciting to be at the beginning of this development. So it's pretty easy to talk and sort of tell the residents what to do. But I do want to show that I've been doing stuff, also trying to walk the walk a bit at the VA. So for those familiar with quality improvement methodology, there's usually a thing called a Kaizen board, which is Japanese, and it's sort of a way that you can see the progress of your projects, and I just sort of appropriated that for myself. So this is a list of the projects that we've been doing at the VA, and more stuff get added every other week or so. But this is a pretty thorough list of what I've been working on. And just to point out that half of these projects involve some element of information technology, and then half are inspired by actual patient harm or near-miss events. And we'll focus on one of these now, which is this thing on CPRS view alerts. Now, I'll say a little bit about the background. So this project was started from a patient safety incident where a veteran did not have results of a CT scan he had performed communicated to him as a result of a very sudden, abrupt, and unanticipated resignation of his primary care doctor. So he never received those results, which were abnormal but not critical. And subsequently, as a result of this error, down the road, he ended up needing emergency surgery at an outside hospital. So this is the background. We did a full root cause analysis about this and looked at ways, which is what the purpose of an RCA is, to prevent similar occurrences from happening in the future. So to start that work, the first thing that you have to understand is the process involved. So to help us do this, QI folks create something called a process map, which is what you see here. And it can seem complicated, but I think what you can tease out from this is that there are two separate processes involved in results notification. This upper portion, which involves phone calls and that warm handoff from provider to provider, is for critical results. Remember, this patient's result was marked as abnormal, but not critical. So he goes down this lower pathway here. So this is what happens for sort of normal or non-critical results. And immediately you notice how important this particular node is. This is one of the most upstream nodes in this process, and this is the result notification alert that is put in the electronic health record. And that alert goes in this box here. It's the inbox, so similar to an Epic inbox for those folks working in the UW system. So there's the primacy of this alert, and then we can see the ways that things can go wrong. So in the event that the provider, the primary care doctor, is unavailable, typically they have a surrogate assigned that's supposed to look at these results. If that surrogate is not assigned, then it goes into this thing which we've called the black hole. But that's not the only way that things can go wrong. If there's just a general lack of attention on the part of whichever provider gets the alert, then there is delay and potential for inaction. And in terms of the surrogate process, that was somewhat messy, and so this is my surrogate process, surrogate that I just learned about last month. And this is Vin Gupta, who graduated 2 years before me, and he was, as of April of 2016, still my active surrogate for. So obviously there's some stuff that needs to be cleaned up there. So again, there are two failure modes that we want to address. But by looking at this, we can also see that this is the current state, and from here, this is what we need to do. So this is the reconfigured state that we are trying to build. So we want to place a safety net here. So what form can that safety net take? So we looked around for just general guidance within the VHA, and there was mention about these things, the automated cascade alert, something called backup reviewer. And it turns out there is a function in the electronic health record called backup reviewer that will automatically forward these alerts that are processed within a certain time to someone else. But historically, it has not been turned on at our VA. So the big question is, why hasn't it been turned on? And so this is what backup reviewer does. This is the snippet of that inbox again. And for backup reviewer, it will sort of give this sort of forwarded flag to notify you that it's from someone else. So we dug a little bit deeper, and this is what we realized was the problem. This is about a month's worth of just turning it on and having me be the recipient of these alerts for primary care. And you'll notice that it generated 400 such forwarded alerts. So automatically, that shows you why we haven't turned it on, because there is a vast volume of noise that no one can handle, right? So, but we looked a little bit deeper at what these 400 constituted. And it turns out that 2/3 of this type that happens with what's called a disusered user. And that's when an account, the person leaves and their account kind of goes dormant and inactivated. And there were some familiar names in this list, names like Juan Lessing or Michael Aeneas. And we're like, those people haven't been at the VA in ages. And it turns out where these alerts were coming from is from personal lists of interesting patients. And so anytime that these are started, what happens is when that notification is created for the first time, it's cloned. So even though in the background, the primary doctor managing this patient is taking care of everything and nothing is being is not being attended to, the fact that there's a clone, that clone sits dormant because the user is no longer there. And then it triggers the alert. So we can get rid of about 2/3 of the noise by just eliminating, the term we used was nuking all of the personal lists in the database and having people who need a record of interesting patients use that, go through Excel or some other method. And so that left about 100 of these as true alerts and not from the disuser type. So we looked at that number a little bit more as well. So this is that 107 figure, and it turns out that almost all of them are this particular type, which is order needs clarification, and that's what these are in a string here. And these are flag communications. So for house staff who have worked at the VA, you know that pharmacy sometimes flags an order and sends you an alert. That's what these are. And different from other alerts, these have to be actively unflagged. So there's an extra step to clear these alerts. And you'll see that one particular provider, provider D over here, generated about 1/4 of the total volume of these forward alerts. So this is an opportunity, just looking at this, that perhaps this person doesn't know that there's an extra step. So the next logical step here is to ask, hey, you know, try and verify what it is about this that's causing 23 when everyone else has 1 or 2, right? So this is cut off. There are more people down there, so the number 2 does not match up with the number 8. But what that leaves, out of 400 messages, 8 were real ones. And what we're going to do next then is to go through this process of cleaning up the lists and just turning it on for the general surgery service. They have the fewest personal lists, and to see if we can get it down so that the person who receives these flags only receives single digit, not 400, but less than 10 a month, then this system then becomes usable and our safety net can go live. So that's one of the projects we're working on. That's a fairly complex project. And there's an element of provider satisfaction in that, in the sense that we're trying to cut down on electronic notification noise, but QI does not necessarily need to be so complicated. So this is another project that we did, and that was sort of trying to optimize the short call under the new iCompare system at the VA. So this project was completed in about 14 days, 30 seconds per day, with basically just one short Excel sheet asking when that short call intern, so this intern is taking admissions but does not stay overnight, that's repeated every 8 days, when they leave, and the goal for departure was 10 p.m. So, and our mascot for this project was the VA version of Captain Planet. We called him Colonel Quality. So, but basically, through these 14 data points, what you can see is that this is a fairly stable system. So there is some intern to intern variation in speed, but that oscillation occurs within limits. And for the most part, it's fairly stable. And the average time out the door was 10 o'clock, and the shift length was about 15 hours. And working with Dave Wenger and Jeff Redinger, the clinical inpatient chiefs, what we decided was based on sort of plotting what seemed like reasonable caps, that we set the limit for the total admissions for that intern at 3 and the last admit to be at 5 p.m. And I believe that is a system that has been in place since the fall. So this took 14 days is completely provider facing. And so it doesn't need to be complex. So in terms of the take-homes for what quality improvement is, right? So first part, healthcare processes are exceedingly complex. QI methods provide a framework for unraveling that complexity, and that complexity must be fully understood if the processes, in order to improve the processes effectively. So there are plenty of ways that you can think of to do certain things, but unless you understand where the lever points are, you risk wasting effort or expending too much effort or wasting money and all these other things. And that those improvements pay dividends over time in the form of safer patient care, but not only that, but also better joy of practice, better provider satisfaction. So QI is applicable in pretty much all circumstances. And I'll say that one major truth in all of the stuff that I just showed you is that in order to fix that problem, or in order to start fixing that problem, first had to be informed that it existed. So you can't fix a problem about which you are not aware. And I think that is a key concept. So let's talk about awareness for just a brief bit. This picture I have up here, this is Colonel John Boyd, and he's one of the most famous fighter pilots in the annals of the United States Air Force. He has never shot down a single enemy fighter. But what he's known for is for systems thinking. So he is one of the architects of the strategy around the first Persian Gulf War. But he's probably best known for conceiving of something called the OODA loop. I'm not sure if anyone in this room has heard of it, and it's a kind of a funny name. But what it stands for, OODA, is Observe, Orient, Decide, Act. And this is a way to describe decision cycles in your head, decision cycles in your team, decision cycles in your organization. It is a basis of military strategy. How do you get a quicker OODA loop than your opponent? In business, how do you get a quicker OODA loop than your opponent? You name it. And so what I like about the OODA loop is that it concretely links in series a decision to do something with first an orientation of where you are, so situational awareness as the preceding step, and the one before that, what gives rise to that situational awareness is observations. So there is an emphasis on accurate observations. And if you think about it, if your observations are erroneous, if they are too infrequent, or if they are just plain non-existent, then the downstream decisions, the risk of that is that they will be flawed, either reacting to the wrong situation or a situation that is no longer relevant because it represents the past rather than the present. And OODA may be a high-level concept, but it's something that is applicable for every moment of every day, and it's something that physicians actually know intuitively. So if you think about your patient who is clinically deteriorating and your opponent is E. coli, let's say, what do? You try to increase the accuracy and frequency of your observations. You update the labs. You send them to a unit where they can get one-to-one monitoring. You put them on continuous telemetry. Stick in an art line. All of these things are done to sharpen the accuracy of your OODA loop and to shorten the refresh time. So this is something that we practice in clinical medicine every day. And this is at an organizational level, what happens when OODA breaks down. So this is Volkswagen here. And you'll probably be aware of the fact that they had a recent scandal where their employees gamed some emissions testing systems. Management says that they didn't know about it. Breakdown of OODA loop and the total cost is $18 billion to this date. And here's an example closer to home. So this is a photo of the central processing unit at Harborview, where they take surgical instruments after procedure, they clean them, sterilize them, and repackage them for use in the next procedure. And earlier this year, I had the opportunity to participate in a rapid process improvement workshop around missing instruments. There's a milk carton there to advertise this event. And that was, and that was set up by Anders Chen and Sarah Grossrup at Harborview. And it was a great experience. And so this idea, again, the topic was missing instruments. And in the investigative process, I had the opportunity to go to central processing and the ORs, which is definitely the first time I've done that since medical school, totally foreign environment. and then interviewed the staff. And so if you interview the central processing staff, what they were concerned about was instruments that are not returned in the trays that they get back from the ORs, and those instruments subsequently had to be replaced at some cost to them. So you go to the ORs, and what they're worried about are incomplete trays, trays that come from sterile processing that should have a certain instrument for a case, but that lack that instrument, or that instrument may be there, but it's broken. So automatically you see that this idea of missing instruments actually meant two very different things to the two groups involved. Furthermore, in an interview where she was quite upset, one of the nurses in the OR said that basically, I get missing instrument trays every day. They're maybe a little bit embellished, but certainly conveying her sense of frustration at this process. Now, that's news to central processing, because central processing has an error-free rate that they've recorded of 99.8%. So where does that number come from? It comes from this sheet. This is an inventory that gets sent down with the trays, and the OR nurses are instructed to sort of mark items that are missing or broken on this and return it. The OR nurses they basically told us up front, they are so frustrated with the process and the lack of improvement over time that they feel this sheet is a waste of time, and they basically throw it away. So here's a breakdown that now sterile processing does not get the feedback that they may be sending broken instruments or missing instruments. So how can they fix that problem if they don't know it exists? And if they don't know it exists, then the downstream effect for the nurses is that they still have dissatisfaction over that process. The total cost of this AUDIT breakdown, which is just down the street at Harborview, is $240,000 a year for replacement instruments that they have to buy specifically for this issue. And as a final note, also, what is happening is because they are so frustrated with the process, the OR staff, when they see a broken instrument, they deliberately throw it away in the garbage. So some of those instruments may be repairable, but because they don't trust central processing, they want to definitively remove that instrument from circulation, so they chuck it away. So for central processing, their problem of missing instruments, some of that comes directly from a deliberate action by a customer or a colleague that no longer trust their services. This is what happens when AUDIT breaks down. And of course, that financial cost is $250,000 a year. The impact to a patient who is on the operating table or who is waiting for surgery, no amount of money can be placed on that impact. So again, for any organization to make the right decisions to learn, adapt, and thrive, then they have to practice the AUDIT loop. They have to make the right decisions, which is based on situational awareness, and what feeds that situational awareness is observation. So in this giant healthcare organization, all of UW Medicine, serving 1.5 million patients a year, who supplies those observations? It's you, in the form of this, okay? So this is the PSN. This is maybe a derogatory term and a verb, depending on how you use it. But this is the program that we use to monitor for defects in the system. And in fact, the name of this program is actually Systems Intelligence, but because that's shortened to SI, we can't really use it in our hospitals. And so as an example of how this works in actual practice, these are data from the VA version of PSN, which is the Electronic Patient Incident Report, the EPR. And so this is just all of the medication errors that have been filed over the last year. And we break it down through the analysis, and you can see that about equal numbers in days and evening nights, but there's a different number of these sorts of missed dose errors. And these are errors like aspirin stat, nitroglycerin stat, not given. First dose antibiotics, not given. Anti-epileptics, not given. So based on this, just based on pure numbers, where, if I am in charge of the VA in the patient safety role, where should I focus my efforts? It's fairly obvious. And just on the flip side of this, we talked about Volkswagen as an example in business that did not get this right. So what happens if you do get it right? So this is the story of Alcoa. Some of you may be familiar with it. It's published, or it's told in this book by Charles Duhigg, The Power Habit, and was brought up by Goop Dhaliwal at one of the recent Leadership Development Institute sessions. But basically, Alcoa, which is an aluminum manufacturer, was in some dire straits in the 1980s, sagging profits. And they brought in this maverick CEO named Paul O'Neill. So Paul O'Neill comes on, and instead of addressing his investors and saying, we'll focus on return and growth and all these other things, he said one specific thing. He said, we will focus on employee safety. And what he did was he made it, he started to ingrain the culture that workplace safety violations should be reported. And he was extremely aggressive in promoting that culture. So this is a culture of safety. This is a just reporting culture. For the people in that sort of supervisory role, this is the most important thing. So as the CEO, he drilled that into his employees. In fact, the only time that you could get in trouble was if you obstructed that reporting. So there's a very there's an anecdote where he goes down to Mexico and fires a longtime manager for basically blocking reporting. And that manager, he did this in this kind of creative way where he didn't fire the manager. He told the manager to fire himself. So that's a very public affirmation of a just reporting culture. And this is, it's one thing to say that he was concerned about his employee safety. He is. But the other part of this is that the employees care about their own safety. They will report. And now those reports allow him to get an accurate picture of, as a surrogate, of other processes and other plants that may not be working right. So he used that to shorten and sharpen his OODA loop. Alcoa subsequently turned around, and Paul O'Neill, if you look in your pockets, he subsequently, on the dollar bill, he subsequently went on to become Secretary of the Treasury of the United States. So that's what happens when you get OODA right. So the long-term survival of any organization depends on the successful execution of the OODA loop. And to successfully execute the OODA loop, management must create an ecosystem that promotes reporting. And for all of us frontline staff, report defects. Do not tolerate, ignore, or most dangerously, work around them. Workarounds are like opiates. They are fine for acute situations, but they will get you into trouble, and they will create scandal of billions of dollars if you become dependent on them. Okay. And the goal here is that because there's an OODA in your head, you see things every day and you react to them. The principle is to concatenate that OODA loop with the OODA loop of your team with the OODA loop of the organization. All right, so OODA again depends on observation, and observation equates to data. So let's talk about data for just a little bit. This is the dashboard of a 747 at night over Pakistan. This is the dashboard of my Toyota Corolla sitting in an empty parking lot. First question, just shout it out. Which side is my gas cap on? Left, perfect. For those of you who don't know, this is my public service announcement. This little arrow shows where the gas cap is. So this is a dashboard in any car, and it's a very conscientiously designed piece of equipment that we probably don't think much about. And if you look at the speedometer, there's a lot of information that goes into the back end of this. What it is showing you is speed in miles per hour. Now, it could be in kilometers per hour. They could show you the angular velocity of the tire. They could, in fact, this needle refreshes instantaneously. What if it refreshed every 15 minutes instead, right? So the way that we present data is extremely important to the actions that result. And as importantly, this dashboard is connected to a set of eyes, which is connected to a brain, which is connected to feet that act on pedals that it knows how to manipulate. So this is a data circuit. This is an information circuit. This is what we are trying to get to. And in the clinical world, you have dashboards as well. If I put that number up there, what goes through your head? And how can I improve the presentation of that number, right? So in the world of quality improvement, we haven't gotten quite there in the way that we present data. So this is a dashboard that is available at the VA, and it's about a number of quality metrics, which have a lot of dizzying acronyms. So there is a gap currently in the way that we can present data, and I think that in healthcare generally, we can move towards better presentation of data. So for this particular dashboard, when I started this job as the Chief Resident Quality and Safety, one of the things I wanted to look at was this particular component here called the SMR30 on this dashboard, which is not a good color right now. Right now, that's red. So this is what that particular metric is, and it's the standardized mortality ratio at 30 days from admission. So this is basically the observed to expected rate of death within 30 days of admission at our hospital. In orange is the national performance for facilities like ours in complexity and size, and our performance is in black. And so there was this gap, and part of the project was to understand why that gap was there, and is there a way that we can close it? So the first step is to understand what the metric means. So that means digging into the data definitions, and this is what is posted on the modeling website about what this is. But basically, it distills into this numerator and denominator actual deaths at 30 days over what is predicted. So we wanted to take a look first at the denominator part of this, and the reason for that is that there have been some interesting rule changes. In 2015, there was chatter that Paul Cornea had received sort of in some listservs about the importance of observation status, and so we were trying to figure out, is there something about observation status that affected this particular metric? So just as a reminder, most people are probably familiar with this. Observation status are intended for short stays, essentially treated as outpatients. At the VA, they can be changed from observation to inpatient, or actually backwards before discharge. But unlike the community, unlike Harborview or here, observation status is actually neutral in terms of the payment that the hospital receives in the VA, and the patients actually pay less for an observation stay than inpatient. So there's seems to be a lot of pluses, not a whole lot of minuses to using observation. And just in terms of how this affected the mortality calculations before, very short stays, less than 24 hours, were excluded, but observation folks were included in the mortality measurements. After the beginning of 2015, all obs were also excluded. So we wanted to take a look and see if this had any impact, and we just, this is available through the national VA database, sort of at different hospitals and their use of observation. So there were a couple that basically admitted half their patients chronically to observation, and some that were very low, but then had a major jump between 2014 and 2015. So graphically, MED is Michael E. DeBakey in Houston, and then Palo Alto is Palo Alto. So there was this sort of coincidence between when the rules were changed in terms of excluding observations from mortality and sort of this giant spike. So maybe there was something in there, but then we thought long and hard about this. And really, if you break down all your patients to a matrix like this, the denominator is only flawed if a truly sick patient is somehow documented or is coded as not sick. But most observation folks are truly not sick, and they're coded as not sick. So they would be in this bucket here. And so they really shouldn't have an impact, at least on the mortality data. So if this is a dead end in terms of leads, what about this? So what is the actual performance at our facility? So we deconstructed the SMR30 by the types of diagnoses. And again, one is here, observed to expected, and there was this obvious outlier in cardiovascular disease. And if you broke all of those patients down by sort of their risk as calculated by the computer based on a certain number of factors, this is for the top 3 sort of diagnoses groups at the VA for 2015. This is the upper limit of 10 to 30%. You see that there is this group up here who died. So there's more people in this category that are dying than would be expected just based on what the computer is reading. And then we further looked at performance over time. So this is unadjusted mortality now. This is just pure numbers without sort of adjusting for their complexity. And you see that for the most part, going back to 2006, this number was fairly stable. But then over here, kind of jumps the tracks. And so we wanted to see what was going on there. And just for orientation, this upper line is a line of statistical significance. So definitely here it exceeds that. And there was no change over the same period in the calculated illness level of the patients or in how long they were staying in the hospital. So basically, we didn't audit. CHF represented the vast majority of these cases. 6 of 22 were on medicine, the rest were on cardiology. 2 died as inpatient, the remainder on as outpatient after discharge or readmission. The coding overall followed the documentation quite well, so there wasn't anything that the coders did. Most were on optical medical therapy. About 3 patients potentially either were unknown or I think one had a definite cardiac arrest, may have had an opportunity in ICD placement. But what jumped out at us was this, that 8 of the 22 patients that were counted against us in the mortality measurements were discharged on hospice. And among the 10 folks in that total that were in this sort of second level of illness severity, 7 of them, 70% of those were discharged on hospice. So the majority of these patients were discharged on hospice. So we have patients that are calculated at 10 to 30% chance of dying who are discharged on hospice. So automatically there's a question of, is there something that we are not doing to communicate the severity of the illness? So, and also if you take a look at just the sheer proportion of hospice deaths, so this is just the number of hospice deaths of hospice cases to the total number of CHF deaths, you see that 2015 was an outlier. It was double the rate that in the past 3 years. And if we subtract all of those from all of those years, then the actual CHF mortality does not actually jump the tracks. So this led us to one last tidbit, which is about the fine print behind hospice. And in the way that that particular metric is counted is that folks are excluded entirely. They're invisible if the hospice conversion occurs before they're admitted to the hospital. They are included if they are admitted into the hospital. And this is to deter last-minute changes if a patient is visibly deteriorating and they want to hide that death. So that's the deliberate thing. But also that hospice deaths are counted if it occurs within 30 days of admission, and they're eliminated if it occurs 30 days from admission. So in this particular metric, the fine print specifies that there is something as dying too soon on hospice, and that is within 30 days of admission. So that is something, so that's to highlight the flaws of data, right? So again, this is just coincidence most likely, but what it shows is that people change their data performance very drastically in a very short amount of time. The patients that went to this hospital probably did not change. So you can influence data without affecting reality. You can game the system. But if you game the system, then as an organization, if I'm Secretary McDonald of the VHA, that is a very dangerous game because it degrades my UDA, it obscures my appreciation of reality, and my decisions based on that can become flawed. And just now to take it back to the airplane and how it landed in our particular living room. So like I said, I am a big fan of aviation. I've followed Boeing for many years, and it's a storied company with a lot of revolutionary iconic products. So this is the 707 on the left, the first successful commercial jetliner, and the 747 that we all know on the right. In 2004, this was their next big thing. This is the 787. And this airplane was a technological marvel. It is the first jet to be made of reinforced carbon fiber instead of aluminum alloys. It offers a lower cabin altitude, a higher humidity for the passengers. It saves about 20% of fuel compared to the plane that it replaces. Before first flight, so in the span of about 3 years, this plane sold more than 1,000 units. There has never been performance like that in sales for any other airplane. To put that in perspective, the aircraft that this replaces, the 767, took 30 years to achieve that same sales figure. So this is a revolutionary product. Now, Boeing designed a technological marvel in the airplane itself. In designing the manufacturing scheme, what they became fixated on was this term here, RONA, which is something called return on net assets. And that may seem familiar to you. Is another one of these things with a numerator and a denominator. And so RONA is something that they can report to their shareholders, and it is something that they can also game. You can't really game it you can't really, I guess, optimize it by increasing your income because that's at the control of the customer. But what you can very effectively do is reduce your assets. How do you do that? You outsource like crazy because you don't own any of these assets. All you're responsible for is the final assembly of the components that other people built. Now, in also doing that, what they did was they really degraded their communication and their situational awareness. Now, you can imagine subcontractors upon subcontractors all presenting to you the rosiest projections of their schedule, right? At the top levels, how do you make a decision about that? So this is the most successful airplane in sales in history. And I'll let the headlines reveal what happened next. So that rollout I showed you was in 2007. This is sort of right afterwards. Delay. This airplane was delayed by a total of 4 years from when it was supposed to fly. It was originally projected to cost $8 billion for the total program. That is now topped $32 billion. So this plane will literally print money for the airlines that fly it. And Boeing is now at risk of never making a single penny on the entire program because of gaming the system and losing a breakdown in their AUDIT. And not only that, the fallout of this is that right now in 2016, we should be hearing news about test flights of the 797. We are not. That program has been pushed back to 2030, all as a result of this delay. And in this backdrop, what is going on is that their aging unionized workforce, those medical costs are also rising. And their financial outlook does not look as good as it could have looked. And so in that backdrop, they launched their healthcare sort of, their healthcare overhaul and started the ACN contracts of which we are now a part. So that is how the airplane landed in our living room. Their story now becomes ours, and we can learn from their story. So this is the caution about data. Data on its own is not useful. Useful information is. And to become useful information, it must faithfully represent reality. And that's the challenge for management here, is to make sure that we have displays that do that, represent reality. And incentives tied to data will change behavior. Be thoughtful about what is being incentivized and fix the reality behind the numbers, not the numbers themselves. And I will say, it is okay to fail the numbers. It is not okay to fail the patients. All right, so in conclusion then. So we live in a very interesting time with a lot of change going on. These are just some of the finance-related acronyms that popped up in the era of Obamacare. And these are the mergers that have occurred since I started residency in 2012. So the ecosystem that we are in as a health system, as UW Medicine, and as a profession is changing so rapidly. This is probably the most fluid and dynamic time in the history of American medicine. We've kind of talked about how AUDIT allows an organization to survive by adapting quickly, but it's not just the survival of a business plan that is at stake. It is real human lives. And I think this slide kind of captures the greatest breakdown and the most heartbreaking breakdown of AUDIT that has confronted our profession. This is the number of deaths from medical error based on the most recent estimates, 250,000 a year, 250,000 people a year, making it the third leading cause of death in the United States behind all cancers and heart disease. And we as a profession did not appreciate the full scale of this problem until the last few years. So these are real patients, our patients, being harmed in the places where we work and the work that we do. But this, and this is true pathology, but this is pathology that is entirely within our control. We don't need to wait for a new drug to be discovered or insurance to be pre-authorized. We can make an impact today by contributing to this organization's AUDIT loop and helping it to take that first crucial step to solving the problems that it faces, which is to become aware of those problems. So how do we go about today fixing this problem? Learning QI, that's going to take a while to build, but today we can make an impact. And how do we do that? And again, I come to this: file a PSN. File a PSN about a harm event, about a near miss event, about a concern that you have. It is a single act that if you repeat 100,000 times over 100,000 hours will save 100,000 lives. And for everyone in this room, I urge you to please do this. And for those people in a supervisory position, defend this, which is the right of your employees to do this without fear of reprimand. Follow Paul O'Neill, set the tone right. Support a culture of safety and a just reporting culture, because this is the dark night. But if we as an organization as a profession commit to collectively building and vigorously defending this just reporting culture, if we sharpen our AUDIT loop enough, then we can make progress and we can march into the light of a new day. So in this era of monumental change, I want us to transmit our first principles: primum non nocere, far into the future. I want us to lead and not be led. I want us to run toward tomorrow's dawn. And if we do that, then our eyes will be the first to glimpse the rising sun. So thank you very much. And these are all the people that contribute to this. And I will now turn this over to David Wenger to present the Beeson Award.